Well, this has been extremely informative. But before we end this discussion, I'd like to open up the floor and ask each of you to provide some final thoughts on unmet needs in these two diseases. Why don't we start down here with Ruben?
So I think we've made tremendous progress, but key unmet needs I would highlight is understanding the issue of progression. I think the issue of progression, why do patients progress, how do we monitor it, is crucial. You know, what is the driver of progression in PVERA? How do we impact that? How do the therapies that we have, I think they do have an impact on progression, but we don't have a good way of monitoring it. You know, how do we optimize that? Should we use ruxolitinib earlier in PVERA because it's helping to avoid progression? I don't think we can answer that. Should we use it in everyone with myelofibrosis, even very early on, because it's helping to avoid progression? How do we avoid the acute leukemia phase of the disease, which is the most fatal? So I think if we understand progression, we will be able to better use the therapies that we have, but we'll be able to better design therapies to further impact the disease.
Very good. Mary Frances?
Well, we've come a long way and we have lots of therapies, but we still come back to the point that how can you actually cure or eliminate these diseases? So that still has to be the unmet need. We've talked about JAK2 inhibition. Are we going to have CALR mutation inhibitors in the future, etc.? So the overall picture remains the same as an unmet need. And then the immediate unmet need is definitely in myelofibrosis, where we're seeing all the patients who have had a good response to therapy but are now losing it. Where do we go from here? Which of these agents is going to be of use?
Yeah, there have been some very interesting preclinical studies. Last one, I think at the plenary session of ASH, looking at the pathogenesis of MPNs driven by CALR, which leads to some hypotheses of how we might be able to intervene in that group of patients. Jamil?
I think for PV, pardon me, I think for PV the issue there is a lack of appreciation to the symptomatology that patients have. We have to do a better job at appreciating this and perhaps attending to it, and of course understanding progression and what governs that and what is the impact of next-gen sequencing perhaps in these processes. And for MF, taking care of patients who have significant cytopenias that might compromise treatment even with such an effective JAK2 inhibitor therapy that we have available.
Rami, last word, make it good.
Right, so again, I think it's exciting time. We've definitely made a lot of progress. We have more options to offer our patients. I think we will always strive for medications that will alter the natural history of the disease, improve survival and quality of life. So that's always going to be an unmet need and in a general view. But in myelofibrosis, I see the ruxolitinib failure group as a challenging group. That's an unmet need. We definitely need some new therapies for those patients, and patients that have cytopenias in myelofibrosis are another challenging group, an unmet need. In polycythemia vera, I think I agree. I think we don't pay much attention to symptoms and management of symptoms. And as Ruben even mentioned, there is still hesitancy to change to the newer treatments in those patients. So there is, I think, educational opportunity there and unmet needs for like second-line treatment for those patients, or educate the doctors to use those medications. But all over, again, like I think it's an exciting time. We've learned a lot, and the outlook should be positive.
Agreed. Well, thank you all for your contributions to this discussion. On behalf of our panel, we thank you for joining us. We hope you found this peer exchange discussion to be useful and informative.